You may have spotted that I've gone a bit mad with the sound effects in this one and tried to make it a bit more theatrical. It is your last topic and it's quite a heavy duty one, so I just thought I'd lighten it up a little bit. Okay, so this is part 2. In part 2, we're going to look at cluster headache, tension type headache, and our one secondary headache, which is medication overuse. Not that we know an awful lot about it. And then we'll look at the applied pathophysiology. Obviously, headache is a symptom in its own right, but there are a few other associated symptoms that we can talk about. Enjoy your last topic. Okay, cluster headache then. Cluster headache is a recognised attack. Huh, you have attacks. It's a trigeminal autonomic cephalgia. It's more common in males, often between the ages of about 30 to 50. And as with most things, there is a probable genetic component, and we'll see where that hits, basically, in a minute. It's characterized by cluster periods, so hence the name cluster headache. These cluster periods can last 1 to 2 months. And what the statistics show is that they often start a few weeks after the winter and the summer solstice. So in other words, we have our shortest day at the end of December. So attacks often start in January. Our midsummer's night, within a few weeks of that, attacks start. So there's a key thing here. We've got a couple of times of year when certain thing changes. Yeah, okay, the clocks change. The weather maybe changes. But what's key here is also light. Usually sufferers have a couple of attacks a day, but some people have up to 8 a day, which, bearing in mind how excruciating the headache is supposed to be, it is quite disabling. What they've also noticed is, within individuals, it tends to happen at the same time of day. These key times are 1 to 2 o'clock in the morning, 1 to 3 o'clock in the afternoon, and for some odd reason, 9 o'clock at night. So, in other words, cluster headache is seasonally and circadianly linked. So it has key links to the time of the year and the time of the day. And again, what links these is possibly the amount of light. So let's have a look, bearing that in mind, at what normally happens in terms of how the hypothalamus monitors light and how it responds to those levels of light. So light, basically in the form of photons, is detected by photosensitive ganglion cells on the retina. So we have these specialist light detecting cells. The rods and cones detect light as well, but they use that to form images. In terms of these ganglion cells, this is more about monitoring the levels of light. So these photosensitive cells then create action potentials. The action potentials are transmitted along the retino-hypothalamic tract. So we can tell where they're going to, can't we? They're going to the hypothalamus. The action potentials are received in a specific area of the hypothalamus, so a specific nucleus, little bunch of grey cells within the hypothalamic grey, in other words, the grey matter of the hypothalamus. This little special area is known as the suprachiasmatic nucleus, or the SCN. And this is where light is detected. And you can see on the diagram here, it's quite small in relation to the rest of the hypothalamus, but then bear in mind what the rest of the hypothalamus also has to do. That's hardly surprising. So the SCN, that little green blob you've got there, it sort of sits at the bottom of the hypothalamus. In response to the light levels, the hypothalamus then does a bit of a balancing act between the hormones, and the key hormone, the wakey hormone, if you like, is cortisol. So in response to light, so high levels of light, the hypothalamus stimulates cortisol secretion from the adrenal cortex. Remember, this is a glucocorticoid. A steroid hormone comes from the adrenal cortex. Obviously, it does that in the way that we know, because the hypothalamus secretes corticotropin releasing hormone, which goes down to the pituitary, the anterior pituitary, stimulates the release of ACTH. ACTH goes in the circulation to the adrenal cortex, stimulates the release of cortisol. In addition, and this is where the balancing act comes in, the hypothalamus, when it stimulates cortisol release, it inhibits melatonin release. Melatonin comes from the pineal gland. It's not a gland we've particularly talked about before. You can see it there sitting on your screens to the right of the hypothalamus. So deep, sort of deeper within the base of the limbic system. And it has functional links with the hypothalamus, so the hypothalamus can regulate the release of its hormone, melatonin. Melatonin is the sleepy hormone. So in this case, high levels of light increase the cortisol, the wakey hormone, decrease the sleepy hormone, and consequently, theoretically, with lots of cups of coffee, we wake up and we're ready for the day. And of course, vice versa at bedtime. Melatonin will increase, hopefully, and make us sleepy, and cortisol reduces. So we've got this balancing act between cortisol and melatonin. This dominates our circadian rhythm. So that was normal physiology in terms of the monitoring of light and the regulation of the circadian cycle. In cluster headache, what they've noticed is that people who suffer from cluster headache, there is more grey matter within the hypothalamus. In other words, the hypothalamic grey, as in matter, is enlarged. They've also noticed that during actual attacks, cortisol levels are increased and melatonin, of course, consequently, is decreased. So there's an even more extreme response in terms of light, if you like. And what they think is that the suprachiasmatic nucleus, that little green blob in the hypothalamus, the SCN, is dysfunctional. So what happens is it doesn't respond in a normal physiological way to levels of light. And what you end up getting is abnormal variations in melatonin and cortisol levels during the circadian cycle. So in other words, you have dysfunctional responses to light levels. And because of this, you can think, well, okay, where's the trigeminal nerve in all of this? Again, there are close functional connections, in other words, neurons, interneurons, between the hypothalamus and the medulla, specifically the trigeminal nucleus caudalis. So the hypothalamus can communicate via neurons with the TNC. So because of this, it can activate the TNC. So it's not activating the nociceptors around those meningeal vessels, it's activating the TNC directly, where that primary afferent synapses with the second order afferent. It also, the hypothalamus also has these close functional links, neurons, connecting it to the superior salivatory nucleus in the pons. And hopefully you remember from part 1 what happens in the superior salivatory nucleus, the SSN. This is where that second order from the trigeminal nerve synapses with the parasympathetic efferents of the facial nerve. So we've got a link with an area that, if stimulated, it's going to give us parasympathetic outflow, regardless of what's happening with the trigeminal nerve. So obviously, because of the TNC, it can stimulate the trigeminal nerve. You stimulate the trigeminal nerve, the ascending pain pathway cuts in, and you have headache, you have pain. It also activates the trigeminal vascular system. So because you're activating the trigeminal nerve, you still get that vasodilation at the meningeal vessels. You still get neurogenic inflammation, and you still get sensitization of not only the trigeminal nociceptors, but also at all of the synapses ascending up that pain pathway. So the trigeminal nerve is being stimulated more or less in the same way as if those nociceptors of the free nerve endings around the vessels themselves were being activated, being stimulated. So we've got trigeminal activation. And not only because of that, but also because of these independent neuronal links between the hypothalamus and the superior salivatory nucleus, we can also stimulate the facial nerve, as I said, giving us this parasympathetic outflow. The parasympathetic outflow, if you remember, increases the vasodilation. So it's our neural mechanism, if you like, of increasing vasodilation. But also, if you remember, we had lots of other autonomic symptoms we suggested as a result of this. So the parasympathetic outflow goes to various places, specifically glands of the face, and causes the symptoms of the trigeminal autonomic cephalgia. And this is why really cluster headache is a classic trigeminal autonomic cephalgia. So we have links with the trigeminal nerve and independently with the facial nerve. Okay, here's a question for you. If light levels, presumably, are going to hit both retinas, travel down both retino-hypothalamic tracts, and then be interpreted centrally at the suprachiasmatic nucleus, so they all converge there, why on earth is cluster headache unilateral? Why isn't it bilateral? Yeah, we don't know. Basically, no one knows why cluster headache should specifically be unilateral. Okay, and now for something completely different. Tension type headaches. Now, the pathogenesis of tension type headache is totally different, really, to the others. This time, we're actually moving out of the head. Now, tension type headache, we can divide it into episodic, so ETTH. Episodic is classified as at least 10 episodes on more than 15 days of the month. So for half of the month, over half of the month, you might have 10 tension type headaches. That was bad enough. Chronic is more than 15 days a month, so most days of the month you have a tension type headache. And you have that over a period of at least 6 months. So again, very disabling. In chronic tension type headache, there is a strong familial link. It's a bit like our migraineurs with aura. They tend to suggest that there is more of a genetic component. Whereas episodic tension type headache tends to be more related to environment. And classically, the name suggests that these are people who are under tension, who are stressed. And that might well be true, and we will see why in a minute. The stimulus, what sets this off and ultimately will stimulate the trigeminal nerve, we still come back to the trigeminal nerve, appears to originate from the muscles around the head, the neck, and the shoulders, including the trapezius muscle, the big muscle of the shoulders. These are collectively known as the pericranial muscles. And what happens in these muscles, and this is perhaps where we associate it with this stress thing, they have increased tenderness in those muscles. So think of your own shoulders. If you're stressed, maybe your jaw clenching. So you're stimulating the muscles around your head. You're stimulating the muscles in your shoulders by hunching up because you're stressed. But this intention type headache sufferers, this isn't just during attacks, which would suggest that actually, yes, this is the genuine pathogenesis. It happens even when they're not actually having the headache. So anyone who suffers from tension headache, if you stick your finger in certain trigger points in those muscles, you will find that they have increased tenderness. There's also an increase in the firmness of the trapezius muscle. So the trapezius muscle feels like it's already sort of semi-contracted, it's tense, it's tight, and yeah, that classic, oh, your muscles are knotty type thing. And what they've seen is that people who suffer from tension type headaches, who have a predisposition for tension type headaches, can actually bring on an attack by clenching their jaw for 30 minutes. So that intention type headache sufferers can bring on an attack. And of course, and this has now become more of a mainstream treatment, the use of lidocaine and Botox. Of course, Botox blocks acetylcholine binding, so it disables those neuromuscular junctions. The injection of lidocaine and Botox into the key trigger points, the most tender known little points within these muscles, actually reduces tension type headache. So we can see that the pathogenesis in terms of this hyperreactivity, this semi-contracted state, permanent state in pericranial muscles is most likely the pathogenesis of tension type headache. And they've actually shown that tension type sufferers, headache sufferers, have increased muscle activity and increased contraction in those main myofascial trigger points around the head and neck. So in other words, they have these hyper-irritable areas associated with skeletal tissue. The skeletal tissue itself is semi-contracted, so it's forming tight bands. You're probably all at this point prodding the muscles of your neck and your shoulder, wondering why you don't have tension type headaches. Hopefully you haven't got one. So it's thought that the frequent input, this frequent contraction of the pericranial muscles, will sensitize the primary and second order afferents, so we're ascending stepwise, in the trigeminal nucleus caudalis and, where relevant, for the trapezius muscle, the dorsal horn. So we get sensitization because of this frequent contraction, this frequent stimulation. So, of course, you get local pain. You also get referred pain. There are recognized referred pain patterns depending on the trigger point affected. So you get local pain and you get referred pain in other pericranial areas. And you end up activating the trigeminal nerve. If you activate the trigeminal nerve, of course, you activate the trigeminal vascular system. And this can either be directly or via a complex interaction of interneurons. I remember we've talked before about interneurons forming this grey matter, and they fill that grey matter, millions of them, all interlinking up. If you remember when we talked about cardiovascular, we talked about referred pain in the jaw. And is it possible that that is overriding the dermatomes? It's not like the two primaries sharing a second order. This is about interneurons communicating upwards rather than just at that spinal level. So we have this complex interaction with interneurons. If you activate the trigeminal nerve and the trigeminal vascular system, of course you're going to get headache because the ascending pain pathway is activated, vasodilation is potentially activated, partly due to neurogenic inflammation and sensitization, so calcitonin gene-related peptide, substance P, degranulating mast cells, also sensitization of the nociceptors, and have all the central synapses, both at the TNC or the dorsal horn and at the thalamus. And meningeal vessel vasodilation because of calcitonin gene-related peptide, and also if we manage to activate the facial nerve, the parasympathetic outflow, we possibly get vasodilation from that. Now, the key thing with tension type headache is sensitization, because this is where, as in most conditions, sensitization, particularly in pain syndromes, is about the switch between normal pain stimulation and ongoing sensitization. And if you remember from your pain lectures, this can even lead to structural changes that will cause chronic pain syndromes. So tension type headache is no different in that respect. There is a switch from episodic to chronic due to sensitization and ultimately long-term potentiation of the synapses at every level. Plus, if you remember, we talked before in part 1 about that descending modulatory pathway becoming pro-nociceptive rather than anti-nociceptive. So we have the potential for that switching to pro-nociceptive in tension type headache as well. Chronic tension type headache, as we suggested before, has a stronger familial link. So therefore it's linked to multiple genetic factors. In other words, it's polygenic because it involves changes or potential alterations in lots of different genes. And the way this has been theorized is that the environmental factors, such as stress, of course, will cause the episodic TTH in the general population. And let's face it, we've probably all suffered from a tension headache at some time. But in those that have a genetic predisposition, you're adding another layer here of sort of pathogenesis, really, in terms of genetic makeup. These people can progress to chronic through this central sensitization. And there's a article for you there. It's not an article, it's a link to a series of informative articles, if you like, in eMedicine. Tension type headache, if you want to do any further reading on that. Okay, so those were all the primary headaches that we're going to talk about. We talked right at the start of part one about the classifications into primary and secondary headaches. Of course, secondary headaches are headaches that aren't syndromes in their own right. They're caused by other things. And the one that we're going to talk about is medication overuse, very briefly, because not much is known. But in terms of the other secondary headaches, you can probably more or less work out what is going on, particularly in the case of infections, that sort of thing, trauma, what is happening that is going to stimulate the trigeminal nerve. In medication overuse headache, though, the picture is a lot less clear, and again, there is a lot of controversy. So it's even more poorly understood. One thing about it is it occurs mainly in patients with migraine and tension type headache. Now, we've been through the pathogenesis, both of those, and they are entirely different. Okay, migraine is a little bit unknown, but we came up with multiple theories. None of them were at all like tension headache, which gives us our first controversy. So the pathogenesis of migraine and TTH are very different. So what we can work out from this is that medication overuse headache must have its own pathogenesis. It isn't dependent upon the pathogenesis of the type of headache. In addition to this, we have the other issue that it occurs with all the different types of headache medications, regardless of their pharmacological actions. So they all work in terribly different ways. So how are they all causing the same headache, even though they work in different ways? So that's really our second controversy. Now, one thing that's possible, certainly in terms of our serotonin antagonists, is the concept of compensation. And we talked a little bit about this before, particularly in cardiovascular. Remember, if you've got too much noradrenaline, then the beta-1 adrenoreceptors get down-regulated. So the same works. If you've not got enough of something, the receptors will become up-regulated. And this is what happens if you use a triptan to antagonize serotonin. It blocks the action of serotonin. So the neurons think, oh, great, okay, well, that's all right. I've got some more receptors. I've synthesized some more receptors. I'll express more receptors on my membrane. Therefore, what little serotonin is available will be able to work, will be able to bind and have an action. So if you antagonize serotonin, they have shown that the serotonin receptors, particularly the 5-HTs, 2As, if you really want to know, receptors become upregulated to compensate for that antagonism. So this potentially over a period of time could mean that your triptan doesn't work as well. The other one that some research has been done on is paracetamol. Now, admittedly, it's only been done in rats, but they've shown that in rats, the paracetamol increases cortical excitability. In other words, it's going to increase the potential for CSD, cortical spreading depression. Paracetamol also sensitizes trigeminal nociceptors, so it's doing the job of the neuropeptide, and it upregulates the serotonin receptors. So in multiple different ways, it is increasing the potential for headache, and that covers various headache syndromes, the pathogenesis of lots of headache syndromes. So that's paracetamol. But basically, the jury is still out on medication overuse headache. So, of course, we've actually already talked about two symptoms, massive symptoms. Headache itself is both the syndrome and, of course, it is a symptom. That's the pain related to our condition. So we've talked about headache in terms of being a symptom because we've talked about trigeminal stimulation. In terms of syndrome, of course, we talked about the pathogenesis, what is stimulating that trigeminal nerve. Plus, of course, we've also covered aura in terms of migraine. That was down to cortical spreading depression. So we've covered two of the major symptoms. In terms of other symptoms, not all of them may be present in all of the three primary headaches that we discuss. So we're just going to go through them generally. Many of them occur to central sensitization or the trigeminal autonomic reflex or a few other mechanisms. They're activated in varying degrees depending upon the pathogenesis of the headache. So hence, not all headaches have quite the same symptoms. So sensitization, how does that cause any symptoms then, other than the switch to chronic? We've talked about peripheral sensitization of the nociceptors. So our TRP and our other channels like A6, purinergic receptors with their channels are going to open more readily. Because they open more readily, we have more EPSPs, we have a greater chance that we will generate an action potential at the trigger zone. So that's sensitization in terms of the periphery, at the transduction level. At the transmission level, we're talking about central sensitization. That sensitization of the synapses due to neuropeptides, specifically in this case calcitonin gene-related peptide being exocytosed from the presynaptic membrane. This happens at the trigeminal nucleus caudalis in terms of the trigeminal nerve and at the thalamus. So you remember our central nervous system synapses. We have AMPA channels that are straightforward ion channels, and we have NMDA channels. They're the ones with a little magnesium block in, and we need depolarization, strong depolarization due to the AMPAs to get them to open, but also we need glutamate and glycine to bind as well. So they're less likely to open. They do open, but in greater levels of depolarization. So calcitonin gene-related peptide, as we said, it's exocytosed alongside glutamate. It binds to its own receptors on the postsynaptic membrane, and then via cyclic AMP, so there's going to be a G protein, adenylate cyclase, giving us cyclic AMP, which then goes off and activates protein kinase A, PKA, and protein kinase is, of course, phosphorylate. So we get phosphorylation of the AMPAs and the NMDAs, which gives us sensitized postsynaptic ion channels. So they are more likely to open in response to glutamate binding. In addition to that, if you remember, calcitonin gene-related peptide affects the astrocytes, not shown in this diagram, and the astrocytes regulate the levels of glutamate that's released from the presynaptic membrane. So in this case, calcitonin gene-related peptide also increases the availability of glutamate. So we have the central sensitization at the synapses. This sensitization can move stepwise. If you remember, the trigeminal nerve has 3 branches. So if we stimulate one branch, where they all come together, that sensitization can then move out and affect other branches. And this is what potentially may give us things like facial hyperasthesia. So in other words, the face is more sensitive to pain, but also allodynia, where non-noxious stimuli such as just gentle touch is felt as pain. Long-term potentiation, as we said, can switch these synapses and cause episodic headaches to become chronic. The other thing that we talked about before, particularly in terms of migraine, is that this descending modulatory pathway that is normally anti-nociceptive, it normally, through a whole series of on and off switches, remember at the PAG, then secretes serotonin, which blocks incoming action potentials along primary afferents. So generally, it's anti-nociceptive. But through the alteration, the modification of those on and off switches, those little interneurons, it can change from being anti-nociceptive and actually become pro-nociceptive. So what do we get due to central sensitization? Well, we've already talked a little bit about this stepwise sensitization to other branches. So we can get ipsilateral facial hyperalgesia, allodynia, but also it can start affecting the senses. So we could potentially get photophobia and phonophobia. And this is caused by that stepwise synaptic sensitization of the other ipsilateral, same side, trigeminal branches. But it can switch to the other side as well. And this is because we're also sensitizing at the thalamus level. So we have convergent second and third order neurons all coming into the thalamus. And this can give us contralateral hyperalgesia, allodynia, or referred pain to the head or upper limbs. So it can switch over to the other side due to central sensitization. Or by switching in the descending modulatory pathway, this can become pro-nociceptive. So yes, another reminder, if this is all a bit, oh, what's she talking about here? You need to go back to your module preparation about pain. Okay, so remember our facial nerve. Our facial nerve, if you remember, was the nerve, the efferents, primarily efferents, that we were stimulating by that branch from the second order trigeminal up through the superior salivatory nucleus to synapse with parasympathetic efferents of the facial nerve. And in this diagram, you can see the distribution of the facial nerve. So if we look at those, what do you think could end up being mediated by this reflex? So let me bring in my highlighter here. So lacrimal gland, there we go. If we stimulate the parasympathetic efferents to that, we cause vasodilation, it's a gland, it's going to start secreting more. If we're talking about a lacrimal gland, of course, we're going to get runny eyes. We're going to get tear formation from the eyes. Looking below, we have nasal mucosal glands. Again, same thing. We're going to get an increase in secretions. So you're going to get either rhinitis or congestion due to that. And our oral and pharyngeal mucosal glands. So mucosa in the pharynx. So we're going to get some gunk back at the back of the throat and an increase in that as well. Below that we have our salivary glands, the sublingual, the submandibular, down there. So we're going to get increased salivation due to the stimulation of those by these parasympathetic efferents. And this is basically a large part of our trigeminal autonomic symptoms. Autonomic because, of course, we're activating the parasympathetic efferents of the facial nerve. So, due to the trigeminal autonomic reflex, after activation of the facial nerve branches, we have the classic symptoms of trigeminal autonomic cephalgia. So this classifies these headaches, the presence of these symptoms. And they include all the things that we've just talked about. So we have lacrimation, posh word for tears, conjunctival injection. So think about that one. Parasympathetic efferents, vasodilation, so the vessels in the conjunctiva become more obvious. Tarsal edema, nasal congestion, rhinorrhea, and salivation. So swollen eyelids, runny nose, and increased salivation. And these are classic symptoms of attack. And as we said, this is due to the parasympathetic outflow of the facial nerve branches. The parasympathetic nerves themselves will exocytose their neurotransmitter ACH, which is a vasodilator in this case. Also, if you remember, it recruited some mates, a bit like old RAS likes to have a few mates around. So we have vasoactive intestinal polypeptide, VIP, and nitric oxide. All of these are vasodilators. And it's thought that if the ophthalmic branch, that's the first branch of the trigeminal nerve, is stimulated, then the trigeminal autonomic reflex is more likely. Whether this is to do with the structure, the pathways of the neurons when they synapse or not, who knows? Horner syndrome is another classic sign of trigeminal autonomic cephalgia, but it has a slightly different mechanism. So here we're talking about the bony cavernous sinus. So a cavernous sinus is basically a gap within the bones of the skull. So we have in this gap certain structures. Obviously, if one of those structures gets bigger, that bony cavity can't expand. So it's going to start compressing on the other structures. And here what's happening is the oculomotor nerve that travels through the bony cavernous sinus. You can see it up there. I'll just get my highlighter to play. There's the oculomotor nerve there. Travels through the sinus, becomes compressed. So what's compressing it is the internal carotid artery. So here's our internal carotid artery, this big round red thing here. And you can see it's already quite big. But if that vasodilates due to parasympathetic efferents, it causes compression on that oculomotor nerve. The compression, bear in mind this is an oculomotor nerve, can lead to inhibited sympathetic output. So the parasympathetic outflow is causing vasodilation, which is then inhibiting sympathetic input to the eyelid muscles, the pupil, and the facial blood vessels. Okay, let's just think in terms of the facial blood vessels there. If we're inhibiting sympathetic input, the sympathetic nervous system vasoconstricts, so the facial blood vessels, because of the inhibition of the sympathetic input, are going to vasodilate. So how's that going to look? Yeah, the person's going to look quite flushed. In terms of the other structures, so there's our facial flushing, we get Horner syndrome. Horner syndrome is this combination of ptosis, so droopy eyelid, and you can see there that her left eyelid is droopier than her right. That's ptosis. And also that the pupil is constricted, because remember this is an oculomotor nerve. So Horner syndrome is ptosis and pupil constriction, and it's down to the compression of the oculomotor nerve within the cavernous sinus, and that's caused by vasodilation of the internal carotid artery. There is an article I've got on the VLE about trigeminal autonomic cephalgia. It's quite good in terms of the pathology, the pathogenesis. In terms of treatment guidance, then you need to double check because things may have changed. It is quite an old paper now. Okay, nausea and vomiting. This is primarily a symptom in migraine. It can occasionally happen in cluster headache, but primarily migraine. And as usual with nausea and vomiting, I have to say, the mechanism is not fully understood. So just to refresh our memories, you can see we have our centers there. In blue, we have the vomiting center. This is the one that correlates in the medulla. It correlates all the input from the other areas that are affected that cause nausea and vomiting. Behind it, we have the chemoreceptor trigger zone. So this is about chemicals. It's particularly important in terms of chemotherapies. Above that, we have the vestibular system. This is our old travel sickness, motion sickness source. Higher centers Higher centers are all about fear, anxiety, sights, smells that make us feel sick, all those sorts of things. And GI tract we know about, those mechanoreceptors, chemoreceptors, and of course the GI tract is a major source of serotonin. So all of this feeds into the vomiting center. So what is happening in terms of migraine? What can actually be demonstrated is based on research into the effects of antagonists. In other words, things that help with nausea in migraine. So the neurokinin 1 receptor, so this is the substance P receptor, antagonists have no effect on nausea and vomiting in primary headache. So you can see those receptors there. We have them in the vomiting center itself. We have them in the chemoreceptor trigger zone. H1 receptor antagonists, these are antihistamines, do have a mild effect. And I remember trying to use them on one of my dogs that was travel sick. They have a mild effect, but it's actually thought, and someone told me at the time, that it's not so much down to the antagonism of the histamine receptor. It's about the fact that the antihistamines cause sedation, they cause drowsiness, rather than inhibiting the vestibular pathways that cause nausea. So the only antagonists so far that have proved effective are dopamine receptor antagonists, so for example metoclopramide. Now if we look at the diagram, we can see that the only dopamine receptor we have there is in the CTZ, the chemoreceptor trigger zone. The other one that's proved effective are serotonin receptor antagonists, which are quite expensive. But we can see that we have serotonin receptors in the CTZ again, but also in the vomiting center itself. So we can assume that basically what's triggering nausea and vomiting in headache syndromes, particularly migraine, is the vomiting center and or the chemoreceptor trigger zone. And this seems highly logical, really, when you look at where they are. The vomiting center is in the medulla. That's where the TNC is. The chemoreceptor trigger zone is very close to the medulla. So I suppose you could say geographically, they are in very logical positions to be stimulated in the case of headache. So it can be assumed that whatever the mechanism that causes nausea and vomiting in primary headaches, it's mediated centrally in the medulla or chemoreceptor trigger zone, and that it involves dopamine and serotonin. Other than that, at this point, we don't really know, which is a bit of a story throughout this whole topic of headache, really, hasn't it? It's nice when you get to a bit that we do know, but when we don't know, okay. In terms of you explaining this, when you get to exam conditions, in certain circumstances, of course, you can say, we don't know. But wherever possible, I've tried to present you with evidence that at least eliminates some causes. So what we do know, you can relay, but what we don't know, you can freely admit, we don't know. And that is the end. So, okay, if you want more information, there are a couple of links on Moodle that we've pointed out as we've gone through. Medscape articles, but there's also a few other PDF articles there on there for you.
Three of them are on various aspects of cortical spreading depression. The one, some of them are a bit more complex than others. Cortical spreading depression by Simone is probably the most standard one for you to read. But if it's your field, then go on and read the others. There's also an article there on trigeminal autonomic cephalgias and a very brief handout on upper and lower motor neuron lesions. Which brings us right to the end of your very last topic. And as usual, I have my list of nags for you. So hopefully by now you are really starting to get up to date with the previous topic material, and you just need to now learn this one on top of that. So that by the time you get to your final revision for the exam, which is only 6 weeks away, then your recall will be a lot quicker, and it'll just be a case of refreshing those memories. That's the aim anyway. Good luck.